Hi everyone, I am Dr. Anisha, your microbiology faculty, and today we will be discussing a very important topic, that is HIV virus. And under HIV, we will be covering up its structure, its genome, window period, lab diagnosis along with ART basics. So to begin with, we firstly need to know what an HIV virus is. So HIV, it belongs to family 𝗲𝗏𝗏𝗏𝗏. 𝗲𝗏𝗏𝗏𝗏. So naturally it is a retrovirus. And whenever we talk about HIV, we should remember R for a number of things. Firstly, we have already spoken about it is a retrovirus. Then it is an RNA virus. And it also has a very important enzyme, that is reverse transcriptase, which helps the synthesis of DNA directly from the RNA after infecting the host cells. So this enzyme helps in doing so. So it synthesizes DNA from RNA, and that too retrospectively. So these are the important R's we must know whenever we talk about HIV virus or retrovirus. So now talking about its morphological characterization. Firstly, it is circular in shape and it measures around 80 to 110 nanometer. In HIV virus, it is composed of certain elements. Firstly, let us talk about the envelope. Now, envelope also has two components. One is the lipid part and the other component is the proteins. So firstly, when we talk about the lipid part, it is derived from the host cell. And the proteins are the glycoproteins. And what are the two main glycoproteins that the envelope has or they are embedded with? These are glycoprotein 120 and glycoprotein 41. Very important structural proteins. And the second part is the capsid or the nucleocapsid. Now this nucleocapsid, it encloses the core proteins. So what does the core actually hold? So firstly, it is going to hold the RNA. And what kind of RNA? It is single-stranded, positive sense RNA, and that too linear. So it has two such copies. Two copies of RNA. Whereas it has other important compounds or certain enzymes. And what are these enzymes? First, we have already spoken about. It is the reverse transcriptase. Second one is integrase. And the third enzyme is the protease. Now let us look at the structures or the components with the help of a diagram. So this is the structure of an HIV virus. So firstly, when we were talking about the envelope, it had two parts. One was lipid and the other was the glycoproteins. So this structure, this whole structure, this is the lipid membrane. Whereas two proteins, glycoproteins GP120 and GP41. We'll be talking about their functions in the later section. Then we said that it has reverse transcriptase, which is helping in the synthesis of DNA from the RNA, right? So this is the role of reverse transcriptase. Of course, two strands of RNA, two linear strands of RNA. This is the capsid. So these are the important structural components of HIV virus. Now moving on to the different genes which are associated with the pathogenesis, and they are also helpful in diagnosis of HIV virus. So let us talk about firstly the structural genes and the non-structural genes. So for structural genes, let us remember a mnemonic, that is 𝗪𝗪𝗏 is envious of poll results. So here I am not referring to our famous 𝗪𝗪𝗏, but it is just a mnemonic helping you understand and learn these structural genes. So what are these structural genes? From 𝗪𝗪𝗏, we are deriving the first gene, that is GAG. Then the second structural gene from envious will be taking up ENV. So the second structural gene is ENV, and the third structural gene, it is the POL. So these are the three structural genes, GAG, N and POL. This codes for enveloped glycoproteins, which we have already discussed, and the other functions would be discussed later on. And then we have the non-structural genes. Remember these genes, very, very important, and the most important being N gene. And the non-structural genes are around 6. So what are these? TAT, NEF, REV, VPR, VPU, and the last gene is VIF. So now let's move on to the detailed demonstration of these structural genes and the details associated with these. So let's first talk about GAG. So 𝗪𝗪𝗏, we are again referring to the same 𝗪𝗪𝗏, but now we'll be talking about our famous 𝗪𝗪𝗏. So 𝗪𝗪𝗏, he is the shell and core of an institute, right? And his age is around 55 years. So how are we using this story in our gene? So firstly, when we said he is the shell and core of an institute, so it codes for shell and core proteins, and he is 55 years of age. So this GAG, it presents, or it is present as precursor protein. So initially it is 55 and then it divides into 3 parts. One is P18, the other one is P15 and the third is P24. So when we say that he is shell and core of a protein, so what is the shell protein? So it is P18. This is the shell protein. And these are core. Antigens or proteins we can say. Right? So this particular antigen, P24 antigen, it is a very, very useful diagnostic tool in HIV diagnosis. You need to remember this. So he is 55 years old, shell and core of an institute. So it is present as a precursor protein and which later cleaves into shell and core antigens of proteins. Right? So 18 is shell and 15 and 24 core antigens. Then when we say that Pol, we have another structural gene which is the Pol. It stands for polymerase. So let's remember the next mnemonic, that is 𝗪𝗃-Pols. So what are we deriving from this mnemonic? So firstly, we have E. So naturally it is coding for the enzymes. And what enzymes we were talking about initially while describing the structure? These are the reverse transcriptase, the second was I, that is integrase, and the third one was protease. So now they also have, these genes also has numbers, right? So the numbers are P31, P51 and P66. So older age group people, when we say 𝗪𝗃-Pols, so older age group people, they do not have much to talk about or they do not have much to do in day-to-day life. So they eagerly wait for the exit-poll results, right? So all of these people, I'm not talking about the 31-year-old, but 51 and 66 people, aged people. So they eagerly wait for the exit polls. So this is how we name and learn that the later age group numbers are coding for the pole gene, right? So P31, 51 and 66. Remembering these two structural genes and their important numbers. And these numbers will also be used in later section while diagnosis. Now next comes the end gene, whose major part we have already covered. So these are the glycoproteins. It codes for the glycoproteins. And what are these glycoproteins? Very famous ones, GP120 and GP41. So with 4, we are deriving the letter F. 4 and the letter F. And this GP41, it is the fusion glycoprotein. F for 4, 41 and fusion protein. Whereas GP120, it is the main gene or the main structural gene which attaches to CD4 cells on the host cells for allowing all the important pathogenic steps which are present or pathogenesis related to HIV. So this is the main gene which is attaching or acting as a docking site or attaching to CD4 cells on host cells. Right? So these are the two main important functions of the envelope or envelope glycoproteins. So let us look at these. So these are present as knob-like spikes. Knob-like spikes. Right? And these GP41 structures, these are somewhat transmembrane pedicles. These are somehow embedded in the lipid layer. These are acting as anchoring proteins, right? Whereas GP120 is the site which attaches with the CD4 cells of host cell. So this is how we describe these two important structural proteins. Now, what is the role of non-structural genes? Firstly, the major role of non-structural gene lies in the replication. It helps in replication. And second role, it is for the pathogenesis in vivo. So these non-structural genes are present as two categories. One is essential regulatory genes. So these are regulatory genes. Means they are regulating the replication and they are regulating the presence of these genes and their role in the pathogenesis, right? So one category is essential regulatory genes and the other category is accessory regulatory genes. The other category is accessory regulatory genes. So what are these essential regulatory genes? We have total 6. So 3 for essential and 3 for accessory. Essential ones include NEF, REV as well as TAT. NEF, REV and TAT. These are the essential genes. This is the translational transactivator gene, whereas this is negative factor. And the accessory ones are VIF, VPU and VPR. So this stands for viral infectivity factor. So these are the names that you need to remember from the structural as well as non-structural genes. Now talking about the window period. What exactly is window period? So this is the time interval between the exposure and detectable antibodies in the serum. So what usually happens that these antibodies, they start appearing in around 2 to 8 weeks. but they only become detectable after or between 3 to 12 weeks. Right? So what is that duration in which for early diagnosis we also need to have certain tests, because we cannot wait for this long 3 to 12 weeks to get a positive result, to get HIV reactive results, right? So there are certain tests which are useful during this window period. So what are those tests? Firstly, when we are talking about the envelope glycoprotein or the structure GAG protein, so what was the division of the precursor protein 55? It was 15, 24 and 18. So that was P24 antigen. P24 antigen. So this antigen starts getting detected from around 12 days to around 26 days. So it is naturally earlier than the 3 to 12 week period duration, right? So this is the duration wherein P24 antigen comes into play. This is first duration when this antigen starts increasing and then it vanishes. And it is in later stages of AIDS, later AIDS stages, where it again gets detected. So is it useful in the window period? Yes, it is useful. Then the other test which can be done, a very, very important test which can be done during this window period, it is the HIV RNA detection. HIV RNA detection, it can be done by RT-PCR, real-time RT-PCR, then NASBA, etc. Right? So, not DNA, it is HIV RNA. HIV RNA detection. And what is the time duration from which it can start getting detected in the serum? It can be as early as 10 to 14 days. So this is the lower limit. So within 10 days with this particular test, HIV RNA detection test, we can get a reactive result if the patient is infected. So these are the two important tests which can be done and which are useful during window period. Now let us move on to the lab diagnosis of HIV. So HIV positive status or HIV reactive results are a bit of social stigma, right? So there are a lot of moral, legal, ethical, as well as psychosocial norms which are associated with these. Because this particular infection or this particular syndromic state, it is considered as a stigma. So people usually, they are not very confident about themselves. So we need to be very empathetic towards the patient for testing them for this particular infection or while giving them treatment, right? So these are the important C's that we need to ensure that we follow them diligently while testing or while treating the patient. So first is consent. The second one is confidentiality. And the third being counseling. Very, very important that while testing the patients, we need to have written consent from the patient itself. And then whether the results are reactive or non-reactive. Firstly, HIV positive status should never be written It's a complete no-no. It should never be written on any of the forms which are provided to the patient. So it is never written. So this kind of confidentiality has to be maintained for such patients, firstly. And then we never say it is HIV positive or negative for a patient. We write HIV reactive status. HIV reactive. One thing, right? And then comes the counseling. A thorough counseling needs to be provided to the patient about the nature of the disease, what all precautions he should be taking, whether we would counsel the patient to have that courage to tell the status to his family members, to his partner, right? So a thorough counseling, a very empathetic counseling has to be done towards the patient to tell him about the nature of the disease and all the symptoms and what he'll be going through. Since HIV, it is a lifelong infection, a lifelong state. So the patient has to be on medication lifelong. So that requires a very empathetic route towards the patient. And also while taking consent, before testing the patient, we should always tell him about the nature of the test and what all consequence can occur. It can be a reactive result, it cannot be a reactive result. So all of these things need to be explained well to the patient. Now let's move on to the specific as well as non-specific tests. So what are the specific tests? So for that, we have this mnemonic, that is SSC exam. So first, S is used for screening tests. We are using the second letter for supplemental tests. And the third letter is used for confirmatory tests. Right? And what are the non-specific tests? We all know RNA, viral load monitoring, CD4 counts, neopterin, and beta-2 microglobulin test. So these are the important tests we will be discussing in detail in the later section. So first, let's talk about the screening tests. So HIV reactive status or HIV positive status, it's in itself an emergency, right? So we need to have quick results. And these are also should be very sensitive tests. Right? So what are the screening tests? So let's use this mnemonic emergency itself. So E stands for ELISA, one thing. And then R stands for rapid tests. Rapid tests. And G here denotes what are we detecting? In all the tests, we will be detecting HIV antibodies, right? And what kind of antibodies are we detecting? These are the IgG antibodies, right? So this is how we use G in the word emergency. So ELISA, it gives results in around 2 to 3 hours. Whereas these rapid tests, they have the ability to provide results in around 30 minutes, within 30 minutes. So since we say that this is an emergency state and we require a higher sensitivity and specificity, so what is the sensitivity and specificity for this? Sensitivity is around 99.5%, whereas the specificity is around 98%, right? So now these particular tests, whether it is ELISA based or the rapid tests, which are also based on different principles. So what are these detecting? These are detecting antibodies against HIV antigens. And what are those antigens? These are the structural genes and the numbers which we discussed in the previous section, right? So for HIV-1, the antigens which are to be detected are JP120, JP41. This is the main structural gene GAG. This is fusion protein. Then JP160 and P24. Whereas for HIV-2, it is JP36. So these are the antigens which are used to detect antibodies in these particular tests. So let us talk about the ELISA generations and the most commonly used generations right now for the diagnosis and are included in the NACO guidelines as well. So third, we have two important generations. Third generation ELISA, whereas the fourth generation ELISA. So what is the difference between these two generations of ELISA? So third generation, they are detecting the antibodies against they are using HIV antibodies using recombinant peptides, recombinant or synthetic peptides. So third generation are only detecting HIV antibodies using recombinant or synthetic peptides. Whereas the fourth generation ELISA, they are detecting two things. One, HIV antibodies as well as P24 antigen using same recombinant or synthetic peptides, whereas monoclonal antibodies using monoclonal antibodies for detection of P24 antigens. So these are the two things that fourth generation ELISA are using or are detecting, whereas third generation are only detecting HIV antibodies. So what is the benefit of this fourth generation ELISA over third generation? Since it is detecting P24 antigen as well, so is this type of ELISA useful in window period? Yes, it is useful in window period. So this is an added advantage over third generation ELISA. Now let's talk about the rapid test formats which are available for the screening of the results or screening of HIV. So what are these rapid test formats? Firstly, we have immunochromatographic test, which is lateral flow assay. Then we have dot blot format, which is famously known as tri-dot test. based on the flow-through assay. The third one is dipstick test, which is ELISA based. Right? And the fourth one is agglutination. Right? So these are the three measures which you might get as IBQs in your exams. So first one is the TRIDOT test, which is based on the flow-through assay. So we have three dots. One is the control one, then we have HIV1 and HIV2, right? So this is the consecutively detecting HIV1 and 2, right? Then we have the dipstick, or also known as comb test. So we have the control lines HIV1, HIV2 and whatever test we are detecting. So these are ELISA based formats. Dipstick or comb test. And the third is immunochromatographic test, where we have the control line as well as the test line, right? So this is based on lateral flow assay. So these are the three important rapid test formats which are available. Now moving on to the supplemental tests. So these supplemental tests should be very specific. Should be very specific in their nature, right? So what is the most common supplemental test which is available? It is the Western blot test. And what is this Western blot test based on? So it is based on a principle wherein antigen-antibody complexes, they will be immobilized on the nitrocellulose strip, and they will be provided, or they will be present, they will be expressed as bands. So that nitrocellulose strip would be impregnated with certain structural antigens or structural genes, and with the human serum acting on those particular areas or the antigenic areas, there will be antigen-antibody complexes formed, and they will be present as darkened line or linear lines present on that particular strip, right? So this is what a Western blot strip looks like. See, since I said it has certain structural genes which are embedded or they are immobilized on the nitrocellulose sheet or strip. So these are the structural genes I'm talking about. So we have the 160, 120, then the 41 coding for envelope glycoprotein. Then we have 55, which was also the precursor protein for GAG glycoprotein. Then we have 31, which was for Pol, and P24, of course it is for the GAG, right? So these are the structural genes, and if in case the patient's serum has positive results or it is positive for HIV, so these will be present as darkened bands. There will be darkened lines consecutive to the number of antigens, to those antigens, right? So now you might get you might get all of these bands as positive, and at times, if in case the patient is positive, HIV positive, it can just be present at one particular location. So what are the criteria which WHO has devised? So there are two criteria, one is for WHO and one is for CDC. So WHO says that at least 2 out of 3 structural genes should be positive, or they should have darkened areas or lines. So what are those? It can be GP120, it can be GP41, or it can be GP160, right? At least 2 should be positive. At least 2 should be positive for WHO criteria, whereas for CDC criteria, since it is GP120, GP41, GP160 and P24. So CDC says any 2 of the 4 should be positives. Any 2 from all of these genes, right? Now let us talk about the other supplemental tests which are available. So one we have already spoken about, Western blot. The other one is line probe assay. Third one is immunofluorescence. Whereas the fourth one is radioimmunoprecipitation. So these 2 tests are most widely used in the NACO guidelines as well, and they're included in the national programs as well. So now let us talk about the confirmatory tests. So P24 comes under the category of confirmatory tests, right? So now, since we say that P24 antigen is very, very important diagnostic tool, so its sensitivity and specificity should be very high. So it should be highly sensitive. And specific. Now for you to remember what are the important uses of P24 core antigen. So remember P for a number of things. Number 1 is P standing for period. As already discussed, so P24 core antigen, it is very, very useful in window period. Its detection is very useful in window period. Then second P stands for pediatric cases. So it is also useful for detection of HIV in children. Then the third P stands for progress. That means for monitoring the progression of disease. Then fourth important thing about P24 antigen, it is that it is used for confirmation of HIV. Confirmation of HIV, right? And the fifth thing, it is useful in progressive stages of HIV. Progressive stage. That means it can be useful for detection in later stages of HIV. HIV AIDS. Why are we saying so? Because we have already discussed that P24 antigen not only increases during the 12 to 26 days of infection, but it is also increased in the later stages as well. Right? So this was about the importance of P24 core antigen. Now let's also talk about another important confirmatory test, which is viral RNA detection. So this particular test, it is the gold standard for diagnosis, for HIV diagnosis, right? So it is the most specific, most sensitive, as well as most specific test. Big test. So what are the targets? It is targeting two genes, that is Pol and N, the important structural genes. So firstly, it is best for confirmation. It is best for confirmation of HIV, right? And it can also be used for, one we have already said, it can be used for confirmation. It can be useful in window period. It can be useful to monitor the viral RNA load. It can be useful in pediatric patients as well. It can also provide us the real-time monitoring. And it can also help detect certain resistances if present. Right? So these are the uses of viral RNA detection. So now, since we have already discussed, we have a lot of formats available in the markets which are very, very expensive. At times, these line probe assays, Western blots, these are very, very expensive. So these cannot be used in a regular way. So what NACO did, so NACO devised certain strategies to enlist those patients, whether these are HIV reactive or not, and whether these needs to be confirmed. So they use certain rapid tests in order to confirm the diagnosis, and they reduce the use of these expensive tests so that in certain resource poor countries it is not always possible to provide these expensive tests. Not everybody gets tested with these expensive tests. So that is why NACO devised certain strategies for screening of the patients, right? So first things first, NACO says that irrespective of the CD4 counts, everybody has to be treated. So we will discuss that in the later section. So let's first focus on the strategies. So it has 4 strategies, and we will be using this mnemonic DESN and SOJI. right? Hindi words for submutables again. So we have 4 strategies. 1. Strategy 2A, 2B, as well as strategy 3. So what is strategy 1? It is used for screening of blood donors, B for blood transfusion, as well as transplant. So we use only one test kit, majorly used in blood banks and peripheral centers. So only one test kit is used, and if this test kit says it's a reactive result, then we discard the blood bag or any transfusion material, right? So first letter of the mnemonic B has been used. Then we have the second strategy, that is 2A. 2A is using the second letter E. So E stands for epidemiological results. Epidemiological purposes. So it is naturally used for surveillance. So it is also important for you to know that all these strategies, whether number of tests, maximum 3 kits are being used. And all the 3 different kits that are being used, they should have different principles. So we'll not be using the same kit over and over again. We need different principles for better confirmation and screening, right? So second kit is for surveillance purpose, second test, second strategy. So we'll be using 2 kits here. Then the third strategy is for screening of symptomatic patients. It is done for symptomatic patients. And in this test format, we will be using 3 kits. And finally, the fourth strategy or strategy 3, it will be used for 3 things. So we are using the last 2 letters of the word basin and S from Suchim. So first things first, it will be used for asymptomatic cases, asymptomatic patients. Secondly, it will be used for antenatal cases, antenatal patients. And thirdly, it will be used for patients awaiting surgery. So have we used all the 3 letters, A, N and S? So this is how we learn what are the uses of these 4 strategies, right? So let's look at these strategies one by one and in details. So let's talk about strategy 1. So strategy 1 or algorithm 1, it is used for transfusion or transplantation safety. We've already discussed that 1 kit is being used. If it comes out to be positive, we'll be considering it as positive, and negative, so we are going to discard the sample, right? Destroy the unit of blood as per the guidelines. Then comes strategy 2A, which is done for surveillance purposes, right? So 2 tests are being used, 2 kits. If 1 is positive, we first test 1 and test 2. If first comes out to be negative, we are going to report it as negative result. Whereas if it is first test is coming out to be positive, then we'll confirm it, we'll again do it with the help of a second kit, which is going to have a different principle. So if both of these come out to be positive, A1 and A2, they both show positive result, then we are going to report it as positive. Whereas if second test comes out to be negative, then we are going to report this particular test as negative result. Whether it is first comes out to be positive, and either if negative A2 test is coming out to be negative, we are going to give or report it as a negative result, right? So then comes the third strategy or algorithm 2B, which is done for individuals with AIDS indicator disease, and these are symptomatic patients, right? So we are using 2 or 3 kits, but majorly we'll be using 3 kits. So first test positive and first test negative. If first test only comes out to be negative, we are going to report it straight away as negative. Whereas if the next step which we'll be doing is the second test. So A2, if A1 and A2 both are coming out to be positive, then we will report this test as positive and we will send the patient for post-test counseling as well. And the case with the second test coming out to be negative, A2 comes out to be negative. In the previous strategy, when A2 came out to be negative, we reported the test as negative. But in this particular case, if A2 comes out to be negative, then we confirm it or we do the third test, which is A3 here. So now what is the result? So now A1 is positive, A2 is negative, but A3 again comes out to be positive. Then this is indeterminate result, right? And if A1 and A2 are, A1 is positive, A2 is negative, and A3 is negative. Only if last 2 tests are negative, only then we will consider it as a negative result. So now let's move on to the fourth strategy or algorithm 3, wherein we are using 3 test kits. And this is done firstly for asymptomatic individuals, for antenatal cases, and for patients who are awaiting surgery. So what are we doing? Suppose the first test is coming out to be negative, we are going to report it negative straight away. Then we move on to the second test, A2. If both of these tests come out to be positive, still we are going to do or we move forward with the third test, right? So in this particular strategy, that is 2B, initially when 2 of the tests they came out to be positive, we were reporting it as positive and we were sending the patient for post-test counseling. Whereas in fourth strategy, even if 2 tests come out to be positive, we are still going to go ahead with the third test. This is one major difference between the 2 strategies, right? So if all the 3 tests come out to be positive, we are going to be reporting it as a positive result only after doing the third test. Whereas if the third test come out to be negative, we will consider it as indeterminate test, right? So now when we are doing the 2 tests where one positive, first test comes out to be positive and the second test is negative, anyway we are going to do the third test, as in case of the positive results as well. So here also we'll be considering the third test. So now what is the indeterminate result and what is the positive, or whether it is going to be a high risk case or a low risk case. So if the first test is positive and second test was negative only, and if third test also comes out to be positive, so we will still consider it as indeterminate. Whereas if the first test was positive, second and third come to be negative, then if it is high risk patient, if it is a high risk case, So we are going to consider it as indeterminate. And whereas if there is low risk, if the risk is very low, no comorbidities, CD4 counts and everything else, if monitored properly, only then we would consider it as low risk or negative if the risk is low. If the two tests are negative, that doesn't determine that we will report it as a negative test, right? So this is how we do the strategies and how we are going to go ahead with the three different tests. So how are we monitoring, and what is this one word that we have read so many times in these strategies? It is the indeterminate result. What do we do in such cases? In indeterminate results, firstly, the test has to be repeated after 14 to 28 days, and then the samples have to be sent to the centers or the national units or reference centers for confirmation by Western blot and PCR, right? So this is what we'll be doing for indeterminate results. And what else do we need to monitor along with doing all of these screening tests? One is going to be the HIV viral load, HIV RNA detection. Then CD4 counts need to be monitored. Then neopterin as well as beta-2 microglobulin also need to be monitored. So these are the tests we need to monitor during the testing mechanisms or during results or during giving the patients treatments, right? So monitoring has to be done for every 3 to 6 months. So now let us also discuss one important point or important section of this particular topic. It is the diagnosis of pediatric HIV. So since we said that we are detecting HIV antibodies, and what is the nature of these antibodies? These are IgG antibodies, right? So what are these conventional tests doing? These are detecting IgG antibodies in patient serum. But are these conventional tests or routine tests, screening tests, be useful in pediatric cases? No, because these cases or these tests will not be able to differentiate between maternal as well as the child's antibodies, IgG antibodies, right? So only when maternal antibodies, they disappear at around 18 months, only then the conventional test would be useful. Test useful in pediatric cases. Right? So are we going to follow these routine screening tests for pediatric diagnosis? No. So what are the other tests that are recommended or the tests recommended for diagnosis of pediatric HIV? First things first, it is HIV DNA test, DNA detection, which is done by DBS or dried blood spot test. Then we can also do HIV RNA detection. We have already discussed that RNA will be useful for pediatric cases. Then the other test, a very famous test which is also useful, it is the P24 antigen test. right? And the last one is the IgG tests only after 18 months, right? Now let us move on to the antiretroviral therapy. Highly active antiretroviral therapy, right? So now we have already discussed that NACO says that we are supposed to treat all patients irrespective of firstly CD4 count, age, gender, and clinical stages. So we are supposed to treat all the patients irrespective of these parameters, right? This is what the guidelines say. Now there are certain goals. Since HIV infection HIV is a lifelong condition. So anyway, the virus is not getting killed. The patient is never getting rid of that virus, right? But there are certain goals which are devised by NACO so that a better life can be given to the patients. First is the clinical goal. What are the clinical goals? To provide longevity. To the patient. To have less clinical symptoms. So there should be symptomatic reduction. To give prolonged better life, right? Then virological goals, that includes maximum possible suppression, maximum possible RNA suppression, and what is that? Viral load suppression. Then immunological goals. That means that qualitative and quantitative seroconversion should be present. And then comes the preventive goals. Preventive goals say that transmission should be reduced. So patient should be able to block the transmission to the normal healthy patients. And therapeutic goals. So the patient needs to be given the drugs. So rationalization of drugs should be present so that there is less development of resistance in the patient. Less resistance should be developed in such patients, right? So these are the important goals that we need to know. So now let's move on to the antiretroviral drugs. What are these drugs? So firstly, we have the nucleoside reverse transcriptase inhibitors, and the most important ones which are included in the NACO guidelines are highlighted here. So all these starred ones are important for you to remember: lamivudine, abacavir, zidovudine. These are included in nucleoside reverse transcriptase inhibitors. Then we have nucleotide reverse transcriptase inhibitors, which include the most important one, tenofovir. Then we have the next category, that is fusion inhibitors, which includes enfuvirtide, Coming on to the non-nucleoside reverse transcriptase inhibitors, and these include nevirapine, efavirenz. These are the most important ones. Then the integrase inhibitors, they include dolutegravir and raltegravir, included in the NACO guidelines. Then CCR5 entry inhibitor, it is the maraviroc, right? And next comes the protease inhibitor, which includes ritonavir and lopinavir and atazanavir along with darunavir. So these are the most important ones which are included in the NACO guidelines. Post-attachment maturation inhibitor is ibalizumab, right? So now let us briefly discuss about these target sites of ARV drugs. It is a very busy slide, but it gets very easy once you know what are we reading about. Firstly, when we say that we have protease inhibitor, what do you mean by protease? Protease is an enzyme which is going to break down the protein. So protein cleavage, it is stopped. So those are included in protease inhibitors, right? Then we have reverse transcriptase inhibitors, right? So what are these inhibitors? We have already discussed. We have so many categories: nucleoside reverse transcriptase, non-nucleoside reverse transcriptase. So what are these doing? So they are preventing the transcription. The DNA is getting synthesized from the viral RNA, so it is stopping the DNA synthesis, right? So from HIV RNA to HIV DNA by reverse transcription by reverse transcriptase enzyme, right? So this is the role of reverse transcriptase inhibitors. Then comes the integrase inhibitors, which is not allowing the viral RNA or the HIV DNA into the host cell DNA, right? So it is preventing the entry or integration of the viral DNA into the host structure or host cell DNA. So that is the role of integrase inhibitors, right? Then we have fusion inhibitors. So these are the major categories which we have spoken about, and these are the target sites for HIV therapies. So what is the NACO recommended regime and what does NACO say? Since already discussed that we are supposed to treat all patients. So NACO regime says that we need to include fixed dose combinations, which are provided in one single drug and given at one particular time, at one time every day, one single tablet, right? It is provided at one specific time, right? And it should include three drugs in fixed dose format, FDC, and should be from at least two classes of ARV. So what are these drugs which are NACO recommended for adolescents and adults? So these include TLD. So that is tenofovir 300 mg, lamivudine 300 mg, and dolutegravir 50 mg. So this is the three drug fixed dose combination, right? So this was about the important NACO recommended regimes, the strategies, the drugs, and all the diagnostic tools which are helping us in HIV diagnosis. Now let us talk about antiretroviral therapy. Which is also known as highly active antiretroviral therapy. Now, NACO says that you're supposed to treat all patients irrespective of CD4 count, age, gender, and clinical stages. So, we're supposed to treat all patients. Since we know that HIV, it is lifelong infection. AIDS is a lifelong condition. Virus is anyway not going to get killed, or it is not going to get rid. Our body is never going to get rid of it. But we can have certain goals, or we can provide or get used to that particular condition with certain clinical as well as immunological features, right? So NACO devised certain goals in order to provide a better and long life to the patients. And how does NACO define such goals? So firstly, we have the clinical goal. Clinical goal says that the patient should have a better quality of life. A better quality and longevity with minimum symptoms. The second goal are the virological goals. That defines that maximum possible suppression of RNA or viral load should be there. Then come the immunological goals, which say that there should be reconstitution, immunological reconstitution, both qualitative as well as quantitative. Preventive goals say that transmission should be blocked. So the patient already infected should not be transmitting that particular infection to other healthy patients or other healthy people. So transmission should be blocked or reduction in transmission. And therapeutic goals say that rational sequencing of drugs. The drug should be sequenced so rationally that the virological or immunological goals, they are present, they are doing well for the patient, and the patient should not develop any sort of resistance. No resistance should be there for the patient. So rational sequencing of drugs should be done, and certain drugs should be kept for future purposes also in case any resistance develops. Future store, right? So these are all the goals which NACO has devised. Now moving on to the important ARV drugs and the ones which are included in the national guidelines as well. So we'll be talking about these different categories first. We have the nucleoside reverse transcriptase inhibitors, which have the most important ones are 𝗬𝗎𝗓𝗓, 𝗲𝗏𝗓𝗓, and 𝗘𝗵𝗔𝗏. Then next comes the nucleotide reverse transcriptase inhibitors, which include the most important drug which is 𝗕𝗵𝗆. Then the next category is fusion inhibitors, which include 𝗕𝗵𝗆𝗏𝗏𝗏. Non-nucleoside reverse transcriptase include the two important drugs that are 𝗕𝗵𝗏𝗏 and efavirenz. Then the integrase inhibitors include the 𝗘𝘅𝗕𝗙𝗏𝗏𝗏, 𝗫𝗏𝗏𝗏, the most important ones included. CCR5 entry inhibitors is the 𝗲𝗏𝗏𝗏. Then the protease inhibitor include ritonavir, lopinavir, atazanavir and darunavir, recently included. So these are the important categories. And then we have the last category, that is post-attachment maturation inhibitor, which is 𝗘𝗵𝗆𝗏. Since this is a busy slide, but we'll only read about the important ones and the important target sites for the activity of these particular drug categories. So firstly, when we are talking about the first category, it is the fusion inhibitors. So fusion inhibitors are not just allowing the fusion of the viral antigens, HIV viral antigen, surface antigens with the host cells, right? So this is the 𝗲𝗏𝗏𝗏. Then we have CCR5, antagonist CCR5. So what are these doing? So these are also not providing entry to the virus in the host cell itself. Then the protease inhibitors. So what is the role of protease? It is going to cleave the protein. So protease inhibitor are not going to cleave the protein and will not lead to further synthesis and replication of the virus, right? Then we have the reverse transcriptase inhibitors. So this category of drug, what are these doing? What is the role of reverse transcriptase? It is going to help the synthesis of DNA from the viral RNA, right? So these inhibitors are not going to allow the synthesis, right? And then we have the integrase inhibitors. So what is the role of integrase inhibitors? So these are not allowing the viral DNA into the host DNA. So it is not allowing the integration of viral DNA into the host chromosomal cells, right? So this is the role of integrase inhibitors. So these are the major categories and major target sites which are used for ART drug therapies. So now let's talk about the NACO recommended regime. So NACO says, since we are discussing that again and again, that we are supposed to treat all patients, right? So what is the basic and most accepted strategy for the treatment of adolescents and adult patients? So NACO says that we are supposed to use triple drug therapy. And what is this particular therapy? It is having 3 drugs in fixed dose combination, which are also known as FDCs. So these 3 drugs should be from at least 2 categories, 2 classes of drugs. And these 3 drugs should be given in one pill itself at one particular time duration, one particular time to the patient according to his or her convenience. So only one pill is given which has fixed dose combination of 3 particular drugs, right? So what is that the most accepted and NACO recommended regime? It is the TLD, which includes tenofovir, 300 mg. Then we have lamivudine, 300 mg. And the third one is dolutegravir, 50 mg. So this is the strategy. So what all categories or what all classes of drugs do these come from? So tenofovir, it is the nucleotide reverse transcriptase inhibitor. Tenofovir is from one class, that is nucleotide reverse transcriptase inhibitor. Then we have lamivudine. Lamivudine, it is from the nucleoside reverse transcriptase inhibitor. Nucleoside reverse transcriptase inhibitor, right? So lamivudine comes from other class. And then we have dolutegravir, which is from the integrase inhibitor. Integrase inhibitor. So this is the third class of drug. So this is for HIV-1 patients. So in case of HIV-2 patients, we are going to add one protease inhibitor as well. Protease inhibitor. So any one drug from the protease inhibitor class, right? So this was about the basics of antiretroviral therapy, all the drug classes, NACO regime, the strategies, important strategies, then lab diagnosis, important tests which are used, then structural genes, all the structural genes which are used for the diagnosis of HIV. So this was about the major sections that I have covered in this particular section. Thank you.